We will start off with Dr. Tan Jenkit. So I will introduce first. I will go through how we go first, but we're going to start with Dr. Tan Jenkit first, okay? All right, so joining me today is our very own Associate Professor Dr. Alfiza from the Microbiology and Immunology Department, and Dr. Ikram, okay? All right, so these two colleagues will be the judges for today's competition. Right, so just a brief work around with how today's session is going to work. You have to present the slides yourselves, meaning you have to share your screen. That's number one. So total presentation time will be 10 minutes, 7 minutes presentation, and 3 minutes Q&A. Okay, so yes, I know initially it will be like 7 minutes presentation, 7 minutes Q&A, but we're going to cut that short to 7 minutes and 3 minutes Q&A. So 10 minutes total. I will inform from time to time who will be the next speaker. So just be alert for that. Okay. So we're going to start our first presentation for today. It will be from our colleague, Dr. Tan Jenkit from the Biochemistry Department. His talk will be on comparing the metabolomic profiles of 3 different yeast food extracts using LCMS. Without further ado, Dr. Tan Jenkit, the floor is yours.
Good morning. Can you hear me? Can you hear me? Can. Yes. Okay. All right. Can you see my slide? Okay. So I will start. Good morning, everyone. Sorry for jumping the queue and the noise. I try to find the best place I can because I'm in another event. I'm Tan from Department of Biochemistry. Today, I would just like to present a short result findings from our laboratory on comparing the metabolomic profiles of 3 different yeast extracts using liquid chromatography mass spectrometry. Yeast extract is the cellular content of the cell or the yeast by breaking, is prepared by breaking the cell wall and release the metabolite. It is a rich source of metabolite which has been proposed to have beneficial effect, for example, antioxidants and anti-aging properties. Various extraction methods exist to extract the yeast of the metabolite, and however, the chemical composition of these various extraction methods remain uncharacterized. Therefore, the study of this, the objective of this study is to compare the metabolic profile of this extract from 3 different methods. In the methodology part, so sorry, I can't find a pointer. So in the methodology part, we will first get the single colony of the Saccharomyces cerevisiae of a wild type strain in this study, and then we pick the single colony and propagate it into a broth and culture overnight, and then further diluted and cultured into appropriate concentration, which we are not reviewing here, and then culture for 3 hours, and then we separate from the media and the cell will be the yeast, will be the cell pellet or the yeast. So we apply 3 extraction methods. The first one is known as autolysis, which the cell was further cultured for 7 days, and the cell will automatically lyse. This is one of the properties of the yeast cells. The second method is known as hot water extract, where the cell was boiled at 100 degrees Celsius for 20 minutes. And the third or last method is the rapid spin, where we apply the centrifugal force to break down the cell. All the extract will be centrifuged to collect the supernatant, which is the cell extract, and the debris remain in the pellet. And the supernatant will be subjected to liquid chromatography mass spectrometry for chemical composition characterization. So in the result part, Here we show the 3 different extraction methods. You can see we start from the rapid spin, have the most characterized or identified metabolites. And most of them are amino acids, where hot water extract have the least number of metabolite detected, and autolysis have the intermediate number of metabolite detected. So among all these metabolite, I would like to highlight one of a quick few to discuss. The first is the 2-isopropyl malic acid, which is found in the autolysis method. It is an intermediate metabolite that is from yeast. It is only found in the yeast, and it has been shown to have detoxification properties against heavy metals. So it has a potential to develop into a product against the detox. So for the only product or only metabolite detected in hot water extract, which is the carnitine. Carnitine is a popular usage has been used to increase the exercise performance, and it has been proposed because the result is inconsistent about the beneficial effect. It has been proposed to have beneficial effect against the brain function and also weight loss. Of course, further study on the yeast-derived carnitine will need to be investigated. The last method, rapid spin, if you remember, produced most of the amino acid. For example, the essential amino acid of methionine, histidine, phenylalanine, and of course, it can develop into popular amino acid supplements. So, in conclusion, the autolysis method have produced detox metabolite, and hot water extract, we need a further characterization or analysis by concentrating the extract into a powder form. And the rapid spin produce a rich source of amino acid. So taken together, the yeast cell has a potential to develop into a commercial product. However, the extraction method has to be optimized to produce the desired metabolite with commercial or highly marketable values. With that, I would like to thank you for your attention.
Right, thank you very much, Dr. Tanjeng Kit. So I will open the floor for the judges to ask their questions. And following that, if there are more time, then I'm sure that there are all the participants here can raise your queries to Dr. Tan. Please.
Good morning. So from your project, basically different method produce different metabolites. That's what I can see from your project. Let's say if people would like to do general screening just to find out the effect of certain compound on the yeast, for example, and in terms of the metabolites. So if people would like to see a wide range of product, would you recommend the researchers to do all 3 methods?
Okay, that is the tricky part about extraction method. Yes, if you want, of course, ideally the best is to do a whole profiling, but it's no matter if it's yeast cells or extract your eukaryotic cell or it is a tissue, liquid, biofluid, it all relies on the extraction method, and it is the very specific. That's mean we have to optimize the extraction method. So it is very specific and we can pattern it. So there is no so far, there is no or none single extraction method that can extract all the metabolite in any single sample. That is because of the diverse chemical properties of the metabolite. For example, they are aromatic carbons, they are aliphatic carbons. Amino acid is a double charge, is a positive and negative charge. And some they are polar, some they are non-polar, and also lipid. So it all depends on how we optimize the extraction method and depends what we want to extract.
Thank you.
Okay. Good morning. Thank you.
Morning.
Okay. Your metabolite extracted from different methods.
Yeah.
So you list a few. Okay. So that one, the benefit that you said is from the literature, right?
Yes, it is. Yes.
Okay.
Yeah.
So means that you are at the stage of extraction the metabolite, but not tested the benefit yet.
Actually, we have result is not shown here. We have another student. He was tested already on the antioxidant properties and anti-aging properties. That's why I actually cited in the introduction. So it has shown, interestingly, autolysis method and the hot water extract have a higher antioxidant properties. But from the metabolite profiling, we found that hot water extract have the least number of metabolites detected, and we think it is because of the concentration in the solution. So our current plan is to concentrate the extract into a powder form and then reconstituted into a smaller or more concentrated form.
So from the rapid spin method to there's a fuse, I think from the posters you list quite a few. So not all produce the same effect, right?
Not all means the metabolite or the
metabolites means that different metabolites or chemicals they give a different benefit, right?
Yeah, they give a different benefit. It depends what are the desire by ideally our plan was is what is the ideal metabolite you want to extract. For example, if you want to produce a lot of amino acid from the extracts, then we have to optimize the method.
Oh, okay. That's all from me.
All right. So, okay, sorry. Okay, so Dr. Tan, may I ask one question? What column did you use to run this experiment?
We use the reverse phase column, which is the C18 column.
All right, C18. Would you expect to find different results if you were to use a different column, so a lipid column? Because it seems like this is a polar extraction.
Yes,
right?
Yes, yeah. Yes, it's true. However, if you want to characterize the non-polar or so-called the lipid profile, it is more complicated. We are still thinking because in terms of commercial value, it is more difficult to commercialize in a lipid, in a lipid product because of the solubility. So now currently, usually at the start, we are focused on the polar or so-called aqueous extract because it can it can be produced in different, for example, in the drink or in a dry powder that can dissolve in the water.
Yeah. That makes sense. All right, thank you. So I open the floor for participants to ask questions. If you have, just turn on your speakers, just unmute your speaker and then fire on. Are there any questions for Dr. Tan? No? Okay, so with that, are the judges okay? Okay, so thank you very much, Dr. Tan, for your presentation. So we will move on to the next speaker, which is Dr. Syed. Hold on. Sorry. So our next speaker for today, or contestant, would be Dr. Syed Al-Hafiz bin Syed Hashim from the Pharmacology Department. And his presentation will be on bone resorption markers, antioxidant and FGF23 gene expression after acute and chronic ethanol treatment with abstinence in male rat. Without further ado, Dr. Syed, the floor is yours.
Okay, thank you very much, Dr. Lokman. Sorry, am I audible?
We can hear you clearly.
Okay, right, sure.
All right.
Okay, Assalamualaikum warahmatullahi wabarakatuh, and hi to everyone. My name is Syed Al-Hafiz bin Syed Hashim. I'm from the Department of Pharmacology. So today I'll be presenting my work on bone resorption markers, antioxidant, and also fibroblast growth factor 23 gene expression after acute and chronic ethanol treatment with abstinence in male rats. Okay, so let's get the ball rolling. So alcohol has numerous deleterious effects on bone. So it has been identified as main modifiable risk factors for osteoporosis. And in year 2018, World Health Organization has published a report on the global alcohol burden, and it was estimated about 43 billion people around the world consume alcohol at one time. And out of these numbers, about 200 million males and 40 million females suffered from alcohol use disorder. And even though there's a lot of negative impact that's been reported between ethanol and bone, but also there are several studies being reported the benefit of alcohol and bone. So for example, Ko et al. And Zhang et al. In 2007 has published a report and demonstrated that the alcohol intake can potentially increase the bone density in those who consume alcohol. All right, so what are the justification of this study? So first of all, because looking at the data is inconsistent, so we need more study to prove that. Secondly, because of the number of patients consume alcohol around the world are increasing, and it has been estimated and projected to be increased in the next 10 years. And lastly, because we are moving to an aging society, so especially in those advanced and developed countries, so these are the populations that are at higher risk of developing osteoporosis. So that's why, therefore, our study is aimed to investigate the effect of ethanol intake and abstinence on first bone resorption markers, which we look at osteopontin and traps. Secondly, at the antioxidant status, which in this study we look at glutathione peroxidase, and last but not least is the bone repair status, which we look at the fibroblast growth factor 23. Okay, so moving swiftly on to the methodology. So we utilized the total number of 30 rats, which we received from LARO, Animal Research Lab, University Kebangsaan Malaysia. So all of these rats were randomized equally to 5 different groups, with each group 6 rats. So the baseline group, we straight away sacrificed during straight away after we received it from LARO. And then for control and acute group, we fed them from day 1 to day 27 with MLD, the modified Lye decree, which composed of low-fat cow milk, maltodextrin, and sucrose. And subsequently, at day 28, the control group received bolus normal saline, whereas the acute group received ethanol 2.5 gram, 25% volume per volume in saline, and both groups are sacrificed after 1 hour. Whereas for chronic and withdrawal groups, so these groups are being treated with the gradual increment of ethanol concentration. So from day 1 to day 7, they receive MLD without ethanol. From day 8 and day 10, we introduced 2.5% of ethanol. And at this time, we adjusted the MLD so that we are able to maintain the isocalority throughout the treatment period. And at day 28, the chronic group received, both groups received bolus ethanol injection, and the chronic group was sacrificed after 1 hour, whereas the withdrawal group only sacrificed after 6 hours to allow withdrawal effects to take in. And the left femur was extracted and what sample was prepared for ELISA test. All right. So how do we look at this result? So these results are presented in mean and standard error of mean. So basically, the similar alphabet here represent the significant difference between groups. So for example, in normal salines, in normal group, there's an A here, and chronic group A. So there is a significant difference between normal, control, and chronic. All right, so in glutathione peroxidase, so what we could observe here, so basically there is a slight increment in the acute alcohol group, and subsequently after chronic alcohol administration, the levels of glutathione peroxidase decrease, and after abstinence, it's restored, the levels is restored, and even higher as compared as baseline and normal. So moving on to the trap. So for the trap, what we can observe here, the levels of trap is lowest in the chronic group. And for OPN, osteopontin, there is no significant difference across the group. Last but not least, for fibroblast growth factor 23, so we can observe that the lowest levels is in the chronic group. And after abstinence, the numbers of value increase back almost double than normal. So in conclusion, ethanol reduced the bone resorption as evidenced by trap expression, which reduced in the chronic ethanol intakes. The level escalated again during abstinence. Secondly, ethanol impact antioxidant protection, so as evidenced by decrease in GPX expression, and whereas abstinence are able to increase the levels back. And lastly, the ethanol disrupted the bone repair as evident by decrease in fibroblast growth factor 23 after chronic consumption. And for future research perspective, I would suggest that it would be better if we can include bone mineral density, because this is the gold standard for diagnosis of osteoporosis. And secondly, it would be also better if you can do also bone histomorphometry analysis, so that we can have the quantitative numbers of changes in this study. So with that, I thank you.
Okay, right. Dr. Said,
stop screen share
now. I would like to invite Dr. Alfiza to provide you with the comments with regards to your work.
Okay, thank you, Dr. Said, for your presentation. I just want to know, what do you mean by the withdrawal group?
Hello?
Yeah?
Hello, okay. Yeah, sure. It's a bit of echo down there. Okay, so withdrawal group is the group which basically we allow to have the withdrawal symptoms. So after the chronic effects, after a chronic consumption of alcohol, so after 6 hours, we observe the withdrawal effects, the ethanol withdrawal effect in rats. So basically, we don't really do it in this study, but from the previous study with the established alcohol model, it has been demonstrated that is the withdrawal effect based on the test, elevated mist test, and also open field test.
Okay.
Is it answer your question? I'm sorry.
Yeah, okay. Okay. How you want to say to that? You got the results of your studies that alcohol consumptions gave a bad effect to bone, right?
Yes.
Yeah, with your all scientific names, and how can you approach or tell the community your findings in a layman words to say the effect of alcohol intake?
So I would say that first of all, of course, alcohol intake is not only effects on bone. So we need to see in general, in which first of all, if we say that alcohol, of course, it's first of all, it's intake. The bad effect is on brain. But if specifically on bone, I would say that the bone is increased the risk of osteoporosis, especially in elderly.
Okay, it was a nice presentation. Unfortunately, along the way, during the presentation, there was some technical problem happened to my laptop. Okay, by the way, may I know the novelty aspect from your study? I'm sure the alcohol has been studied in quite many times.
Yes, exactly.
Including in osteoporosis. So what's the novelty aspect from your research?
Okay, number one is our alcohol model is different. So basically the dose of alcohol that we use is slightly lower as compared as other research. So we would expect that if let's say we use a higher dose, and of course we know that there will be a bad effect on bone, but how about if we give it at lower dose? Will it affect bone as well? That's number one. Number two, regarding FGF23, I think this is the first study, as far as I know, that combined with others bone markers, because most of FGF23 gene study is mainly looking at the end stage renal failure and also in phosphate regulation only.
So regarding about the choice of bone resorption marker, so do you consider osteopontin to be bone resorption or bone formation marker?
Well, I would say it's quite debatable, because there are some studies reported that osteopontin is a bone formation marker because it's being produced by osteoblasts. But there are also studies that show that increase in OPN expression would increase also the survival of osteoclast cells, which in turn increase in resorption activity.
Why do you specifically look at just only bone resorption marker?
Okay.
Perhaps maybe can have quite number of other markers as well to tell the story from the bone formation, for example, and bone turnover in general.
Okay. Basically, we have also studied another markers as well, but then it's still under analysis. So for example, I also measure the osteocalcin as well. So as far as our analysis right now, there is decrease in osteocalcin level, especially in the chronic group, but there is no significant difference between all groups.
Thank you.
Okay, thank you, Dr. Ikram.
Right, thank you. Thank you, judges. So I'm opening the floor for the participants to ask questions. Are there any?
Hi, this is Akmal. I have one question.
Akmal.
You said that you use the smaller percentage of alcohol in your study.
Okay.
How do you translate that into the human application? Because in beer, they have like 5% alcohol. In wine, they have like 12% alcohol. So how would you justify that?
Okay. To be perfectly honest, because I don't really sure how to calculate that actually. So I only based on the evidence that we have in the animal study. But if I were to calculate that, of course, I need to know how to change the percentage into the human so that I can do that. So I'm really sorry, Dr. Akmal, because I couldn't answer that, to be honest.
Okay, I just wonder.
Okay,
Why
thank you
did
very
you
much.
choose that percentage?
Okay. I will look that up. So thank you very much.
All right, thank you.
Thank you, Dr. Akmal. Are there any more? No? You can, drop in your chat, then maybe I can read that off if that is convenient for you, for everyone here. So no? So with that, thank you very much, Dr. Said. I really appreciate your presentation. We will move on with the next presentation. It will be from the Department of Biochemistry, is Lee Jun Shin, and her presentation will be on digital learning usage among Malaysian and Japanese medical students, the current trend. So without further ado, Miss Lee, the floor is yours.
Can Prof and Dr. hear me clearly?
You may have to speak up a bit because it's a bit unclear.
Is that better?
Yep, cool. Thank you very much.
How about the screen sharing? Is all that okay?
What, full screen?
So a very good morning to judges, professors, doctors, and fellow researchers. Today I would like to present my study entitled Digital Learning Usage Among Malaysian and Japanese Medical Students, the Current Trend. So over these years, medical education has actually undergone transformation from conventional to digital learning, enabling learning without any time and place constrictions. So how far has actually Japan and Malaysia progressed in transforming medical education? If we look into statistics, Japan was actually ranked higher in the 18th place based on the International E-Learning Readiness Scoring in 2008, while Malaysia was only at 34th place at that time. However, it has been quite some time since the conduction of this survey. Hence, during our clinical attachment at Shiga University of Medical Science, Japan, which I would refer as SUMS throughout my presentation, so we are interested in exploring the difference in digital learning trend between Japanese and Malaysian medical students, particularly in UKM and SUMS. After getting ethics approval from UKM and permission from SUMS, data collection was done. Questionnaires were being distributed via Google Forms for UKM medical students, while for SUMS medical students, questionnaires were being distributed manually by paper. Stratified convenience sampling was used with a target sample size of 286, and eventually a total of 297 medical students enrolled in our study, consisting of 150 UKM and 147 SUMS Year 1 to Year 5 medical students respectively. Data analysis was done via SPSS version 22, and below are our results. So this graph shows the student distribution in UKM and SUMS. So as you can see here, there is a significant difference in mean age between UKM and SUMS. As UKM mean age is 21.67, while for that of SUMS, it is 24.65. This significant difference is contributed by different admission policies between two countries. For your information, in Japan, it is common for the students to enroll in medicine after they have been working for some time, or they can enroll as a second degree. They are students who are in their 30s or even 40s when they enroll in medicine. This is definitely different from Malaysia, as us medical students would normally enter medical course directly from pre-university courses. This significant difference in mean age may play an important role in our study, which we will explore further down later. So going into the main objective of our study, for the frequency of digital learning usage, we have divided into 3 groups, which is high usage, using at least 3 times per week, low usage, using less than 3 times per week, and does not use. Our study found that UKM medical students have significantly higher digital learning usage compared to SUMS medical students. This is surprising as Japan is a developed country and it has all the technology advancement to be the front runner in this field of digital learning. However, in reality, in Japan, they are still adopting a conventional teaching and learning in medicine. However, in Malaysia setting, specifically in UKM, even though our classes are also mostly face-to-face, but we have also technology advancement, such as clinical skills lab, simulation software such as the DXR Clinician, and also learning management systems such as UKM Folio. As I mentioned before, there is a significant difference in our mean age. Hence, we would like to explore further what is the difference in digital learning usage across different age groups. We have divided into 2 age groups, which is less than 26 and 26 years old and above. 26 years old is being used as a cutoff point because we incorporate from previous studies. So as you can see in this graph on the right, UKM has only one group because all our students are less than 26 years old and half of our students have high digital learning usage. While for that of SUMS, for the younger age group, most of the students have low digital learning usage, while for the more mature age group, it has high digital learning usage. When we compare, is there any difference in digital learning usage between these 2 age groups? It shows no significant difference. Hence, we may say that age is not the factor, but perhaps learning environment could play a more important role in affecting digital learning usage. In our case, in SUMS, as the more mature age group students, they have been working before, thus there is a possibility that they have been exposing themselves to all this technology, making them continue using digital learning in their current studies. While for the younger age group, as they directly enter SUMS from their previous foundation courses, and SUMS doesn't really have an environment that encourages digital learning, so this contributes to the low digital learning usage among them. For the preferred digital learning sources, for UKM medical students, ebooks is the most preferred source. This is reasonable as there is abundance of free medical ebooks available online now, and ebooks are pretty convenient as we do not need to bring those textbooks around. While for SUMS medical students, online research article is the most preferred source. This is due to SUMS has prescribed a lot of online research journals, making students to be easily access these online research articles online. So in conclusion, there is a significant difference between UKM and SUMS in which UKM has higher digital learning usage. However, we are not saying that which one is better, as there is still a lacking of literature suggesting the relationship between digital learning and the learning outcome among medical students. However, what we can say that digital learning is a form of novelty in the field of medical education. Technology is here to stay. Hence, digital learning should be fully explored to be made full use as a complementary role in medical education. What we can learn from this? So a suitable learning environment should be developed to encourage digital learning across different ages and different generations of medical students. So this requires collaboration from all counterparts, from policymakers in allocating substantial funds, to county administrations to train staff to be more competent in digital learning, lecturers to be more creative and innovative in their teaching pedagogies, and of course, us as medical students must be more proactive in using all these sources. An holistic approach towards this novelty will be proven useful, especially during this time of as an emphasis has been put towards digital learning, as there is a restriction towards conventional teaching and learning of medicine. With this, thank you.
Thank you very much. Thank you very much, Ms. Lee. So, the judges, the floor is yours.
Ms. Jun, thank you. Very nice, clear presentation and nice research. I'm just wondering, what's your definition for digital learning? Would you consider reading e-textbook as part of digital learning or the conventional way?
So basically, in this research, we define digital learning as a form of learning where students use any kinds of resources which involves technology. So this means that e-books, online courses, online research articles, simulation softwares, or clinical skills lab, all this has been considered as a form of digital learning.
With the current trend in learning and teaching, because there are more resources in electronic form, would you consider that there will be some of the factor that influence the findings of your research?
So basically, if we look, this is a field of medicine. So as medical students, so it is a field that involves a lot of practicals and hands-on practice. So even with a lot of electronic devices or technology in this field, this probably will only play as a complementary role, as hands-on and practical skills is actually still the pillar in our medical education.
Okay, Junzin, okay, what is the impact of your studies, your conclusion, when you say that the digital learning among UKM medical is higher compared to the Japanese students, right? As we know that Japanese is the developed countries, and what you can apply or adopt, what is the impact of your studies lah?
So basically, if we can see that Japan is up till now, they are still using a conventional method of teaching and learning medicine, while for UKM is more to a way of digital learning plays and complementary role. So perhaps we can say that Japan can learn from us actually. So as I still have contact with students from Shiga University of Medical Sciences, actually during this period of COVID-19 pandemic, they actually has started off digital learning as well, as there have been online classes. So I guess these findings could have an impact towards the in Japan community, as they should have made some steps forward in making improvements in digital learning. So is as if let's say in the future there is any more pandemic, so they won't be so panicky in using digital learning in their teaching and learning method.
Okay, in terms of do you mean that what is the standards of the Japanese medical learning compared to us? Which one is higher between Malaysia and Japanese?
Sorry.
Malaysia and Japan. The Malaysia between Malaysia and Japan. Okay, the standard of educations in your mind, you think that they are better than us, or ours is better than?
So if we
Because
look
you said
into
that Japanese have to follow us in the digital learning. Do you mean that by adopting or by using the digital learning will make us better than that?
we are not saying that which one is better, or Japan or Malaysia is better, but since technology is here to stay, and there is an uncertainties in the conventional way of teaching and learning medicine. For example, if during this current pandemic, due to the pandemic, all face-to-face education cannot be done. So this is where digital learning comes into place, so that the education can be continued going on. So I would say, I would still emphasize that since technology is here, so why not we make full use of it, and so that it gives extra benefit to the students and plays an complementary role in medical education.
I have another question.
Yes.
Because I've never been to Shiga and never been to Japan before, and if I'm mistaken, you have some experience visiting the university before, right? So can you please tell us the environment of the university, just in case, maybe let's say for example, if the university is located in a suburban area, perhaps that might be the factor that affect your findings here.
So basically, during our 1 month attachment in Shiga University of Medical Science, so what because we mingle around with students there, and what we can know from them is that there are also two phases, which is preclinical and clinical. So for the, I will start off with preclinical phase. For the preclinical phase, actually, they are pretty conventional, with all purely lecture based. So if compared to us, we have LMS, learning management systems, such as Folio, but for them there is no LMS. So normally before classes, so there are staffs which will print out all the lecture notes for the students before classes. So I guess this is the one of the main difference. As we adopt digital learning, we have ebooks, and for Japanese students, normally they will bring all those thick textbooks to class. I think one of the reasons is because most the ebooks are in English version, but in Japan they are using Japanese. So perhaps there is a limited availability of ebooks in this language. And when we visited the library, even the library, there are textbooks of translated version into Japanese, and it's all in hardcore textbook form. And so far, from the students, they also told us that there are actually limited availability of ebooks. So for clinical phase, so it is somehow similar to us. It is a university hospital, and students undergo different rotation, but it's also more to face-to-face clinical teachings. As compared to us, we have simulation software, the DXR clinician, and then we have clinical skills lab to practice all those procedures. But over in Japan, all it involves some teaching, bedside teaching, and also a more traditional way of teaching and learning medicine, I would say.
Thank you, Ms. Jun.
Thank you, Doctor.
All right. So with that, due to the interest of time, we have to move on to the next presenter. Thank you very much, Ms. June. I have some personal questions, but I think I would deal with you personally. That'll be easier, because there'll be a much longer discussion on that. Thank you very much for your wonderful presentation. Okay, moving on, everyone. Our next presenter is from the Medical Education Department. I would like to call upon Ms. Aida Binti Ali, and her presentation for today will be on differences in difficulty index, DIFI or DIFI, and discrimination index, DI, between OBA items vetted only at the department level compared to items vetted both at the department and the faculty level. Without further ado, Miss, the floor is yours.
Assalamualaikum and very good morning. Can everyone hear me? Hello?
Yes.
Can
yes,
everyone hear me?
you.
Yeah, okay.
Yes,
All right,
yes,
sorry.
Thank you.
Okay, hang on a second.
Are you
Hope
okay? Are
everyone
you
can be
sharing?
patient. Yeah, I'm actually,
Okay, all
my
right.
computer is a little slow.
Okay, no problem, no problem. We have the time because I'm going to start timing you once you start your presentation.
All right, okay. Can everyone see the screen?
Just a sec. It's still
Still loading?
It's started, but yes, loading. Yes. Okay, now. Yep. Now we got
All right.
it. Thank you.
Okay, today I'm gonna share a very simple comparison study in assessment in medical education. I'm Ida, by the way, entitled The Differences in Difficulty Index and DFI and Discrimination Index, DI, between OBA items vetted only at the departmental level compared to items vetted both at department and faculty level. This is actually a part of my dissertation for Master in Medical Education. I'm very sorry. It seems that, okay, a bit of introduction. So basically, one best answer, OBA, is a form of MCQ, which consists of questions then followed by a selection of answers where students have to select only one of the options, which is the most correct, and the other ones are distractors. In order for us to quantify the quality of OBA, basically we do item analysis after examination to look at, I'm very sorry, the difficulty index, which is the percentage of students who answered an item correctly. Basically, the higher the percentage, the easier the questions. And the second one is we want to look at the discrimination index, which is the item's ability to distinguish between high scoring student versus low scoring student. The way we calculated it is by looking at the differences between the ratio of high scoring student getting the answer correct minus the low scoring student answering the question correctly. For every OBA items that we constructed, before we administer in examination, it has to go through vetting procedures to maintain the quality standard of examination. We screen for technical problems and language problems, and also look at the content related validity. In our university, in the medical faculty of UKM, we use OBA in end of semester as well as professional examination. For validity assurance, every OBA items constructed has to be based on assessment blueprint that covers the content of UKM curriculum for doctors of medicine. And every single item is constructed by content expert lecturers that have gone through training workshops on OBA construction. We have two different procedures for vetting. For EOS, it's only done once internally in the department, but for professional examination, we do it twice, once internally in the department as well as centrally at the faculty level. For evaluation and monitoring, after examination, all the questions will go through item analysis for us to look at the value of DFI, difficulty index, as well as the discrimination index. Okay. As you can see before that, there is actually two different procedure for vetting for EOS and professional examination. So this research is basically to look at the differences in difficulty index and discrimination index between the OBA items vetted only once at the department level compared to those that are vetted twice, both at the department as well as centrally at faculty level. The method we use are quite simple. We take the value for difficulty index and DI index and compare the means through independent t-tests using SPSS. The samples that we used were 222 OBA items constructed for professional examination from 2017 to 2019, and 175 OBA items constructed for EOS examination from 2018 to 2019. Okay. From this study, the result that we can get for the difficulty index, we can see clearly from the first figure, from the first box plots, there is no significant difference in mean DP for OBA in EOS and OBA in professional examination. Both of the examination have a mean DP of around 60%, which is of acceptable difficulty. However, if we look at the discrimination index, unexpectedly, we found that the mean discrimination index for professional examination is a lot lower than the mean discrimination index for end of semester examination. The cutoff value for poor discrimination index is anything that is below 0.2 will be considered as poor discrimination, and we can see that professional examination shows slightly lower than 0.2 at 0.19 discrimination index. Okay. The difficulty index, from the result, we can see that the difficulty index for OBA items that are vetted only once in EOS seems to be comparable to those that are vetted twice in professional examination. This can be because both EOS and professional examination actually goes through the same content expert vetting at departmental level. The only difference is that professional examination has to go through another level of vetting centrally at faculty level. Although the results are comparable, this doesn't diminish the value of central faculty vetting for professional exam, because professional exam is quite different from EOS, where in professional exam consists of OBA items from multiple departments. So it is important to actually compile it and vet it centrally for standardization and consolidation. There's in addition, there's a research in IMU done in 2017 that shows that central vetting does increase qualitatively, it does increase the construct quality in terms of appropriateness of content, higher cognitive testing, as well as item flows. The unexpected result of higher mean discrimination in items that are vetted once compared to twice can be attributed to the samples, the cohort differences of the samples. So it is affected by the personal variation in test takers' level of intelligence, knowledge, and possible learning experiences. And another thing is that professional examination is quite a different examination compared to EOS. Professional examination cover a wider content coverage, cover a wider content of learning content compared to EOS that only covers a specific content that is learned in that specific semester. There is also a possibility that difficulty index and the discrimination index are also influenced by other factors such as test wiseness, where students use guessing strategies based on item flows and hints that are in the questions, as well as irrelevant difficulty. Having that in mind, we recommend a further study comparing OBA item vetted once and twice, but tested on a single cohort instead of a different cohort to actually remove the variability of cohort differences. With that, thank you very much. Questions?
Right, thank you, Ms. Aida. So I open the floor to the judges to ask questions.
Good morning. So basically, it's good study. May I know for the end of semester, which semester of the learning, the one that you include in this study?
There's actually multiple departments and semester. That's from semester 3, semester 2, as well as second year semester 4 and second year semester 3 and 4, and first year semester 1 and 2. Yeah.
But the pro exam that you include in this study is the pro exam for which year?
5th year. So the
So the don't you think that I mean, because the year of study can be also some confounding factor that can attribute to the differences in the between these two examinations.
Yes, that is one of the things that I've considered. The reason why we do this study is because this is part of my dissertation for masters. I'm looking at relationship between difficulty index and discrimination index. Because of the limited samples that we have, I have to use both from professional exam and EOS exam. So the reason I do this is actually to look if there is actually a very vast difference between EOS exam and professional exam in terms of difficulty and discrimination index. But we do think that part of the reason why the discrimination index is different is because of the cohort difference in terms of their experience and the time frame where they are in the medical education. I mean, that one is from EOS is mostly from the preclinical year, and the professional exam is actually at the end of their clinical year.
So because of that, don't you think that for professional exam OBAs can be not so discriminative?
Yes, I do think that one of there is a study on OBA that says that like the longer the students, the more experience the student have with OBA, the higher the possibility of them to be to use guessing strategies and have a test wiseness in answering OBA question. So yeah, that could also be the reason why the discrimination index for professional exam is a lot lower than end of semester examination.
Thank you.
So that's why.
Okay, Ms. Aida.
Yes, I.
Okay, when you see there's a difference between DI, right?
Yeah.
Between the EOS and pro exam. So, and do you think that it's because of the numbers of vetting sessions, or it is because of the format or the type of the questions?
The main thing is that we can't really make a definitive conclusion whether vetting has, I mean, like whether this is solely the effect of vetting, because there is also other factors that I've talked about before, which is the cohort differences between professional and end of examination. That is why at the end of the study, we recommend for us to do, maybe we can do a paired t-test of OBA items before and after the second vetting.
Because EOS is more specific to that particular module, right?
Yeah.
So we have to discriminate. Whereas the pro is more general. They have a multiple question from different departments. Right?
Yeah.
Okay. Thank you.
So.
Hi, my name is Akmal. You just said that they are confounding factors in affecting the discrimination index for pro exam, right? Based on your literature reading, is there any way that we can improve the discrimination index by counted in the all the confounding factors that you have mentioned in the presentation?
So practically what we can do is that from after the what we can do is that one is, I think we have to look at the qualitative quality of the OBA questions in terms of item flows. There are a few guidelines available for checking item flows in OBA constructions. One is has 31 criteria that has to be followed for to get a quality OBA questions. And another thing is that it highlights the importance of post-examination monitoring using item analysis and actually reviewing and actually looking at possible item flaws in detail after the item analysis, if you can get what I'm trying to say. Yeah.
Yeah. Maybe that's good for if you want to construct a question bank. So all of this data actually very beneficial to to choose which question is good, which question is bad, which question need to some amendation. So so basically it makes sense.
Okay.
Thank you very much.
So are there any other participants that want to ask Dr. Aida or Aida? Miss Aida? No? Okay, so with that, thank you very much, Miss Aida, for your presentation.
Thank you.
So we'll move on to the next presenter. Is Miss Su Min from UMBI. And her presentation is on the overexpression of LRG1 suppresses overexpression of LRG1 suppresses autophagy mechanism, possibly via TGF-beta superfamily in colorectal cancer. Without further ado, the floor is yours, Miss.
So good morning, everyone. Can you hear me?
Yeah, you may have to, draw closer to the screen because I think it's a bit, we can't hear you quite clearly.
Okay. Hello, everyone.
Yeah, cool.
Okay. Hi, good morning, everyone. I'm Sumin from UMBI, and today I would like to present my work on LRG1 and autophagy in colorectal cancer, or CRC in short. So a brief introduction about LRG1 and autophagy. LRG1 stands for the leucine-rich alpha-2 glycoprotein 1, and it is a secreted glycoprotein. The increased expression of LRG1 has been implicated in several cancers, including colorectal cancer. It has been reported that the expression of LRG1 is increased in a stage-dependent manner, and it correlates with tumor size. Concordantly, previous data from our lab has verified that LRG1 is indeed elevated in both the serum of CRC patients and also the CRC cell lines in a stage-dependent manner. Furthermore, our previous work has also shown that the LRG1 protein promotes the proliferation, migration, and invasion of the colorectal cancer cells. So to bring this forward, we would like to study the effect of LRG1 on autophagy mechanism, which plays a protective role in cells by preventing DNA damage and also limiting the malignant transformation. Hence, the objective of this study is to elucidate the autophagy signaling pathway in LRG1-mediated colorectal cancer cells. So in order to study the LRG1-mediated signaling pathway, we employed an overexpression model by transducing the LRG1 lenti-ORF into the colorectal adenocarcinoma cell lines, HT29. Then we proceed with the antibiotic selection and colony expansion. So upon verification of the LRG1 overexpression in the HT29 cells, that we then proceed with the quantification of the expression markers of TGF-beta signaling and also the autophagy markers by real-time quantitative PCR. The PCR results were then analyzed with GraphPrep Prism. So from our results, we can see that the TGF-beta signaling markers are downregulated in the overexpression of LRG1. Similarly, the autophagy markers were also downregulated when LRG1 is overexpressed. So taken together, we postulate that LRG1 may suppress autophagy via the TGF-beta signaling pathway. So in summary, LRG1 attenuates the TGF-beta signaling pathway and eventually reduces the autophagy activity as shown by the reduction of the autophagy markers. So this impairment of autophagy would then promote the survival of cancer cells and also supports the progression of colorectal cancer to an advanced stage. So with that, I thank you.
Thank you. Thank you very much, Ms. Su. The judges, the floor is yours.
Okay. Nice posters and nice pictures on the slides. So can you tell us what's the function of LRG1? Is it transcription factor or some protein that do certain function?
It's a secreted glycoprotein. It plays a role in neuronal differentiation during the early stage of the embryonic differentiation. So that was the main function found. And so we would like to explore if LRG1 is linked to autophagy.
So is it a receptor?
No, it's a secreted glycoprotein.
Okay. So, but it goes to meaning that once it is secreted by certain cells, it can go to other cells. Is it?
So it's secreted into the serum. And then it would bind with other factors like TGF-beta1.
Okay. In your methods, you basically do the transfection into a colorectal adenocarcinoma cell. Yes. So, does this cell usually overexpress LRG1?
So we screen a few colorectal cancer cell lines and we choose the cell line with low endogenous expression of LRG1 to do the transduction of the LRG1 overexpression.
So basically the overexpression is because of the transfection of the LRG1.
Yes.
Okay. Thank you, Dr. Alfiza.
Okay. Thank you, Xiumin.
Yes.
So this LRG1 is secreted by what type of cell?
Sorry?
The cells that secrete this LRG1.
It's mainly liver cells.
Secreted by liver cells. So I don't have questions.
I have another question.
Yes.
Because you mentioned that the LRG1 is a secreted protein.
Yes.
But the results that you're showing here is basically showing the effect of transfection of the LRG1 on the cell that is expressing the LRG1, correct?
Sorry, I can't get you.
All right. So you mentioned earlier that LRG1 is expressed by other cells. So this protein is secreted and then go to the other cells, correct?
Yes.
But what you're showing in your research here, the results of your research here basically tells what's the impact or the effect of LRG1 overexpression on the cell itself, not to the other cells. Is that correct?
So in normal people, LRG1 is expressed mainly in the liver cells, but in the patients with colorectal cancer, so the colon cells would increase the expression of LRG1, so that leads to the reduced autophagy and it supports the cancer cell survival and the progression of the cancer. Does it make sense?
Yes. So basically the PCR, you're doing the PCR on the colorectal adenocarcinoma cells.
Yes.
Not taking the LRG1 express and then do it to the other cells, right?
No.
Okay. Thank you.
Thank you.
So the LRG1 also is secreted by the cancer cells.
Yeah.
So it's that one yang secreted by the cancer cells have the same functions with the one yang secreted from the liver cells?
So because in the liver cells it's slowly expressed, so when in the patient of CRC, so it is highly expressed by the patients.
Okay, so means is that they have the same functions?
Yeah, just because that different levels of expression. So it is homeostasis.
So the LRG1 that expressed by the cancer cells, they also suppress the autophagy?
Yeah, the LRG1 expressed by the cancer cells suppress the autophagy, and that leads to the survival of cancer cells and the cancer progression.
May I know your opinion?
Hmm?
May I know your opinion? What's the application that we can get from your research here?
So if we know that the overexpression of LRG1 could reduce autophagy and promotes cancer, so it could be used as a biomarker to see if it could be used as a diagnostic marker to diagnose a patient, and it could also be used to monitor the treatment given to the patient. And drugs could also target the autophagy pathway since it is suppressing the cancer progression. Since it is suppressing autophagy.
Do you have any data or from literature review the level of LRG1 in colon cancer? Whether there is a difference between stage 1, stage 2, or stage 4, stage 2, different stages of cancer. How is the expressions?
It is increasing in a stage-dependent manner.
Increasing. So significant increase in stage 4, right?
Yeah.
So in stage 1, how is the expression levels? Is it different from the normal persons?
Yes.
Yes. You have data on that one to show that the LRG1 expression is significantly different in stage 1 of the cancer?
I don't have it now.
From the literature it shows. From the literature it shows that the LRG1 is significant difference even in the stage 1 of the cancer, or it's just the high expression in stage 4.
It's significantly different. So the normal, then the stage 1, the stage 2, the stage 3, and then the stage 4.
To say that there's a potential biomarker, you need some data from the patient samples lah. Not depends only on the like from the this one in vitro, right? We have to support with the data that from the clinical samples.
It has also been listed as a protein biomarker, cancer protein biomarker by Cohen et al. In Science 2018.
So it's already proved that it's already reported that
They listed them as a potential biomarker. It's not validated yet.
All right. So with that, I think we have to stop with the interest of time. Thank you very much, Ms. Sumi, for your presentation. I thought it's a nice presentation. I can relate to it. So yes. So thank you very much again, Ms. Sumi. So we will continue with our presentation with Dr. Emilia Osman from the Parasitology Department. And her presentation will be on disseminated microsporidiosis, discovery of enterocytosome circulating proteins as potential diagnostic markers. Without further ado, Doctor, the floor is yours.
Okay, hi, Assalamualaikum. Actually, I'm Shaza, presenter for.
Okay, my bad for that. Sorry.
I'm just representing Dr. Emilia Osman. Okay, but it's okay. I will present this research today. Okay. So let's start. Okay, finding a potential biomarker for a parasitic disease is like a hunting job, but this hunting session is in a lab, is done in a lab with a high-tech machine. So let me bring all of you today to our adventure of finding the circulating protein of parasite as a potential diagnostic biomarker. So before we start, let I introduce to you the main star of today's story, which is Enterocytosis zumbainisi. So Enterocytosis zumbainisi, it is a microsporidia, a species of microsporidia, a very small intracellular parasite. It usually can be found in 8 patients, and normally this parasite potential diagnostic biomarker. So this is our main storyline today. Now let's move toward the methods that we use. So firstly, we must find the source of our main star that might hide, which is in the blood of the HIV patient. So we collected 100 blood samples from Hospital Sungai Buloh and TB camp. And the blood samples were then subjected to PCR analysis in order to detect the DNA of E. binacy. So the PCR method was modified a little bit from previous established PCR method for this particular parasite using 2 samples, but we are using blood samples. And the gel band of the positive samples were then sent for DNA sequencing to make sure that the DNA is really E. binacy. And the next step is we use the positive samples and proceed to short-term proteomic analysis. But before that, the most crucial step when using serum samples is that we need to remove the high abundant proteins of the serum. Why is that? It's because that in serum, there are a lot of high abundant proteins that might mask the appearance of the circulating proteins that we want to find. And among the high abundant proteins, we decided to remove the top highest abundant proteins, which is albumin and IgG. So the removal of these 2 high abundant proteins was performed using albumin and IgG depletion kit from peers. So after that, the depleted samples were then concentrated and digested, and then the digested protein were inserted into the mass spectrometer. And we use two different mass spectrometer machines in order to get the best result. And we also use the raw data obtained from the mass spec machine and blast it with two types of different search engines, which is Mascot and Sequest. The identified protein was then analyzed using bioinformatics analysis. Okay, now let me share with you our results and findings. So in this part, the results are divided into three sections: genomic analysis, proteomic analysis, and bioinformatics analysis. So in genomic part, as I have mentioned earlier, we have successfully detected the DNA of the parasite using PCR analysis. So there were 7 positive samples out of 100. And these 7 samples were then proceed to proteomic analysis by using 3 replicates. Using an arbitrary mass spectrometry machine, the raw data obtained was processed using Sequest search engine and was searched against microsporidia and human database. And the results were shown here. We found that there were 2 proteins repeatedly found in the analysis, which is B7XK00 and B7XHF2, uncharacterized protein and actin. However, the peptide score is not good, it's less than 2. This might be because the nature of the protein that we found is really in small amount. As I mentioned earlier, this parasite is usually found in intestine and not localized in blood cells. It's just using the blood as a transportation in order to move to other parts of the body. So to overcome this problem and to confirm whether the proteins detected are really there, we used another proteomic search engine to validate the result. It is also known that when we are using proteomic approach, it is best to combine 2 or more search engines in order to get the best identified protein. So here we use Mascot. We use the same raw data and then from the previous analysis from the sequence, and the results are quite good. We managed to find the same proteins found in the previous analysis, which is B7XK00 and also B7XHF2. And we also found another good candidate protein as it appeared in all 7 positive samples, B7XIN4, which merit further analysis. And this finding was already patented this year. So the B7XD00 and B7XIN4 are an uncharacterized and hypothetical protein. So in order to learn its characterization and other information of the protein, we perform bioinformatics analysis. So from various online software used, we can predict the protein characterization, its domain, localization, solubility, and we also predicted the 3D structure using Fire software as shown in the figure. So as a conclusion, this study is able to reveal the circulating proteins of E. binary in the serum of HIV patients. So the proteins detected B7XD00, B7XHF2, B7XIN4 merit further analysis, and it can serve as a potential diagnostic biomarker for disseminated microsporidiasis. Thank you.
Thank you very much, Shaza, for your presentation. So, judges, please.
Okay, Shaza, thank you for your presentations. So you've got 3 proteins. Do you know what is the functions of the proteins?
Okay, at first, because the protein is hypothetical and uncharacterized, so we can only predict the function. So because it is the domain, we use the domain, we predict the domain of the hypothetical and uncharacterized protein, and then when we got the result, this is the domain in which the function is nearly to chromosome segregation protein SMC. But this one we don't have, we don't know the function. It cannot be predicted. The protein for B7XHF2 is acting. It does not need to be predicted.
So there's what is the prevalence of your E binary in HIV patients? The prevalence
in Malaysia.
Yeah.
Okay, in Malaysia, previously it's 8.5% in literature.
So it's a significant contribution or significant infections in HIV patients.
Yeah.
They give a bad impact, consequence to the patients.
Yeah, usually microsporia will infect or give a symptom of chronic diarrhea to the AIDS patient. So if it is not detected early in early stage, if it's disseminated, so it might increase the mortality rate because there are no treatment in the early stage. And usually when the E-Vanusi was only found to be disseminated after post-mortem, so it's very, very late. So we are trying to detect it earlier.
Very nice presentation and also very nice project. I'm just wondering, let's say from this research, you managed to identify markers. So what's the usual treatment to combat against this microsporia?
Actually, E-Vanusi does not have a really compatible drug yet. So by finding this protein, we might also predict the drug target. We might also do the drug target. It's very important because E-Vanusi still don't have a relevant or a good medication.
I'm a bit curious. Your samples, all of them are HIV positive blood, right? Hello.
All HIV, yeah.
Could you please speak louder?
Yes, it's all HIV samples.
Okay. So would you still expect a lot of IgG in your blood samples?
Sorry?
Do you expect will you still expect a large abundant amount of IgG present in the blood samples?
Of course, because in HIV patients, there will be a lot of disease or infection in them. So IgG is still the biggest highest abundant protein in serum. So for sure, we need to remove IgG. It's still the biggest high abundant protein in serum, whether it's high or not.
All right. All right, so with that, we have to end our presentation by Shazza. Thank you very much for your presentation. Hopefully the panel went through. Okay, so we have to move on. Apparently one of the participants have to step forward. So I will call upon Nurul Nadia from UMBI to present her work. It's deciphering cryptic intratumoral hallmark of TGI beta isoforms in triple negative breast cancer. So I'm terribly sorry for Dr. Anissa because this is a short, how should I put it, a notice that I just got from her. So I would love to, we'll proceed with the list after Nurul's presentation. All right. Thank you.
Hello.
Yes.
Assalamualaikum.
Waalaikumsalam.
Okay, so can everyone hear me?
Can I have Shaza to stop sharing your screen?
Is it my turn now? I'm Nurul Nadia.
Yes.
Okay. Thank you. Thank you for the consideration. Okay. Sorry. Okay. Okay. Can everyone see my slides?
Yes, we can.
We can.
Oh wait.
Nadia presented number 9.
Okay. Okay, Assalamualaikum and good morning. I bid to panel of faculty judges and all. I'm Nurul Nadia with project titled Deciphering Cryptic Intratumoral Hallmark of TJ beta isoforms in Triple Negative Breast Cancer, DNBC, under the guidance of Dr. Izani Azlina from UMBI. So, what is DNBC? Breast cancer subtypes first discussed in 2000 by Perot and colleagues using hierarchical clustering of gene expression data from DNA microarray, namely luminal A, luminal B, basal-like, HER2-enriched, and normal-like. So, because the MBC cells lack the hormone receptors for estrogen and progesterone and do not overexpress HER2 gene, treatment often involves chemotherapy, radiation, and surgery. So why are we targeting TGF-beta isoforms? TGF-beta is suggested to play a dual role in TNBC from a tumor suppressor to an oncogenic promoter. So the three major mediators of TGF-beta signaling pathway, which are TGF-beta isoforms 1, 2, and 3, have different tissue-specific expression and are encoded by distinct genes. In the later stage of cancer, tumor exploit TGF-beta signaling to regulate EMT, metastasis, and cell stemness, which leads to chemoresistance. So these are my objectives: to identify differentially expressed genes, or DEGs in short, stratified by TGF-beta high versus low status of each isoforms in TNBC via in silico analysis of publicly available datasets. So the next one is to identify the top hit pathway in TNBCs. Okay, here is my method. 4 independent dataset retrieved from GeoExpression Omnibus database were incorporated, composing of 493 TNBC samples. So these datasets were obtained from the microarray platform Affymetrix gene chip human U133 arrays. Identification of the DEGs was performed through Partec using ANOVA stratified based on TGF-beta status high versus low. So the cutoff threshold of twofold and false discovery rate FDR with p-value of 0.05 to avoid the occurrence of false positive results. Okay, here it is. And then the next one is gene ontology function and pathway analysis of the DEGs were performed through the search tool for the retrieval of interacting genes, or in short, it is string, using gene lists with fold change between -2 and 2 with unadjusted p-value of 0.05. So string database provides a comprehensive set of functional annotation to understand the biological characteristics involved. We use string to construct protein-protein interaction, or PPI, network DEGs based on the known and predicted PPIs, then analyze the functional interactions between the proteins. Based on the string online tool, PPIs of the DEGs were constructed with a confidence score more than 0.7. Okay, so the last one is the survival analysis through Kaplan-Meier plotter. Was employed by specifying selection to ER negative, PR negative, HER2 negative, and basal-like subtypes to analyze the expression levels and prognostic values of potential genes. So this classification method could show the survival probability differences between high expression group and low expression group stratified with TGF-beta status in each isoforms. Okay, so here is the results and the hypothetical mechanism. From string analysis, these are the among top hit pathways selected based on hallmark of cancers, accounting for the progression in TNBC in each isoform of TGF-beta, where we selected only exclusive significant genes to each of these isoforms. So top hit pathways associated with TGF-beta 1, as you can see in the table, include immune system process, protein metabolic process, and cellular response to stimulus. So next, top hit pathways within the TGF-beta 2 network are namely the cellular component assembly, regulation of macromolecule metabolic process, and cellular metabolic process. So lastly, as you can see from the screen here, is the top hit pathway within the TGF-beta network are extracellular matrix organization, cell adhesion, response to drug, and angiogenesis. So the algorithm of the pathway was based on the false discovery rates, which is the FDR. So we further narrowed down the exclusive gene list of each TGF-beta isoforms and found that, okay, so this is, here is the hypothetical mechanism for each of the isoform for TGF-beta 1, 2, and 3. Okay, so here let's move to the TGF-beta 1 first. Okay, so in the network, ASPN and Sargent were upregulated. So from Turu reading, which I found, Lee and colleagues reported that upregulation of ASPN gene promotes cell migration and invasion in cancer via TGF-beta pathway. So we paired these findings with Kaplan-Meier plotter, which reveals the concordance of outcome. Whereas study by Zhang et al., Sargent or its alias PRG genes expression levels were significantly higher in TNBC cell lines compared to non-TNBC cell lines in regulating cell migration. However, the Kaplan-Meier plotter showed an opposing directions as low expression of Sargent lead to bad prognosis. Okay, so moving on to the next isoform, which is the TGF-beta 2, we identified TTC is exclusively expressed in TGF-beta 2 isoform network. So the literature review has led us to findings of TTC3 as EMT promoter mediated through TGF-beta signaling, which was reported by Kim and colleagues. However, same as Sargent, Kaplan-Meier plotter was going opposite direction, whereby the downregulation of TTC3 causes bad prognosis. Okay, so I'm finished with that. The last one is the TGF-beta 3 isoform network revealed two significant genes, CDH11 and PLXDC1. Overexpression of CDH11 were associated with EMT and extracellular matrix synthesis, according to Ma and the research team. On the other hand, Craven et al. Showed that PLXDC1 amplification in cancer correlates with TGF-beta pathway. So via Kaplan-Meier plotter, both genes contributed to bad prognosis with their high expression. So overall, this is in silico analysis is the first step of my research to determine the direction of my downstream experiment later by validating the identified significant genes in the stable cell lines panels. Okay, as for the concluding remarks, this result exhibited distinct genes and pathway involved between TGF-beta isoforms. So furthermore, common pathways across 3 isoforms were identified. Further elucidation of this marker signature is warranted to understand the underlying mechanism in the progression and treatment response in TNBC. Okay, so correspondence is Dr. Izani Azlina. That's all from me. Thank you for your attention.
Right, thank you. Thank you, Nurul, for your presentation. So, Dr. Ikram, Professor Amriza, what was yours?
Congratulations, it's a high-end experiment and research. So, in your opinion, out of these 3 TGF-beta isoforms, which one do you think is the most significant in TNBC, and which one will you proceed for your downstream experiment?
Okay, actually, throughout the literature review which we have found, most of the research done, they actually focus on TGF-beta 1. Okay, so there's more research references regarding TGF-beta 1 in the action inside the cell migration, anything regarding connected to the hallmark of cancer. Whereas we don't know the the significance of the other isoform. As you can hear just now, there's 3 isoforms: TGF-beta 1, 2, and 3. So we need to actually do more literature review on this and to see, because these 3 isoforms, they have a different tissue-specific expression. So we don't know which one might cause the progression in cancer, in TNBC. So that's why I cannot say based on what my opinions. Regardless, I have to check using the in silico analysis first, okay, which I already done right now, and then I will check using the in vitro experiment just to check back whether does it concordant to what I've found from the literature review previously. Okay, that's it. Yeah.
But yeah, from your reading, in your opinion, which tissue or which cell is most likely will be main source for the
Expressing.
main source for in the progression of the cancer.
Okay, because the TNBC itself, okay, it starts at the myoepithelial cancer, which is metaepithelial cells for the TNBC, right? So for TGF-beta itself, it is expressed throughout any cells. It's just that when there is chemoresistance, because due to the cell migration, cell invasion of the cells, we want to postulate, or maybe it's because of TGF-beta isoforms. Maybe they are the one who actually play a role in the disruption of the cell architecture. Okay, so that's what we want to see. So by that, because from the NBC itself, from what I read, okay, the metastasized site will be to the bone and the lungs. So most probably the cells gonna be migrate and invade to those areas. So that's what we want to check. How these TGF-beta isoforms, maybe they have different biological mechanism. That's what we want to see, the differences in the isoform itself, okay, and how they actually affect the cells, and how and how the cells actually this contribute to the formation of cancer and later metastasis. So when we have metastasis, then we have there's a postulation about cancer stem cells due to there's the rise of EMT. So when they have cancer stem cells, so this depend few readings I've found is this will lead to chemoresistance, which what we want to find out right now. We want to identify what is the cause of the chemoresistance. So that's why we're choosing TGF-beta isoforms, because it plays the dual role in cancer progression. At first, it is act as tumor suppressor, but then in the late stage cancer, it becomes an oncogenic promoter. Yeah.
So are you saying for your in vitro study, you're going to use the epithelial cells?
Oh, I'm using cell lines. I'm using cell lines, which is I cultured in the lab, currently.
What cell line is it?
Okay, so currently I take care of 8 cell lines. We are using the cell lines of normal light cells, which is 184A1, MCF10A. Okay, there's 2. Another 2 is from luminal breast cancer, which is T47D and MCF7. Another one is TNBC basal A. We have 2 cell lines too, which is MDA MB468 and HCC1143. And the last one is TNBC basal B, which is MDA MB231, HS578 and HS780. So overall, I am going to do in vitro experiment using these 8 cell lines, but my focus will be on TNBC basal B, which is MDA MD231, sorry, and HS5780, because this is what I'm going to look at. Yeah.
Thank you.
Okay.
Is there anything that you want to add, or because we're a bit down on time?
I just want to say that, Nadia, do you think that by blocking of this TGF-beta isoform can, let's say, help reduce the poor prognosis in patients?
Okay. Actually, there's quite a lot of beta isoform as not TGF-beta as drugs. Currently, the first approach in targeting the ligands using small molecules to prevent the TGF-beta synthesis on mRNA level. Secondly, is the approach entails inhibition of receptor ligated interaction using ligand trap. And then there's another one, is the third approach is involve usage of small molecule receptor kinase inhibitor to prevent the TGF-beta signal transduction. But however, most TGF-beta targeting drugs are currently either in preclinical or early of clinical testing for different types of cancer, such as breast, pancreatic, and pancreatic. So, but currently, I think fresolizumab, which is a monoclonal antibody, is undergoing phase 2 to develop, in which intended for treatment of cancer and fibrosis. Okay, because my project is on TGF-beta isoforms, currently there is no research regarding the TNBC doing TGF-beta targeting TGR beta in TNBC specifically, triple negative breast cancer. That's why I'm doing this research. Yeah.
All right.
Thank you, Nadia, for the extensive.
Okay, thank you very much, Nadia.
Okay.
We shall continue with the next presenter,
Thank
Dr. Anissa Nordin from the Parasitology and Medical Entomology group, and her presentation would be on isolation of acanthamoeba from air conditioning outlets in HCPM, UKM. So without further ado, Dr. Anissa, the floor is yours. Right. All right.
Oh, shoot. Okay, I'm sorry. Okay, let me hang up. Let me hang up first. Okay, thank you, Dr. Lokman. Assalamualaikum and good morning, everyone. Thank you for the opportunity to present and discuss the finding of our research today. And as everyone can see from the title, the research is to detect the presence of acanthamoeba species from air conditioning outlets in HCTM. Okay. So just a little bit on the background, especially for those who are not familiar with the organism. Acanthamoeba is a free-living protozoa, and it can be isolated from various natural habitats and also from engineered environment, such as water networks and HVAC system. HVAC stands for heating, ventilation, and air conditioning systems. And in recent years, there is an increased reports of CNS infection by acanthamoeba, causing a condition known as granulomatous amoebic encephalitis, or GAE. And it is also one of the cause of keratitis, especially amongst contact lens users. And AK actually stands for acanthamoeba keratitis. And this amoeba also able to host other pathogens and protect them from harsh environment. And this is because the dormancy stage has a thick double-layered wall which are resistant to desiccation and some biocides. So based on these three aspects, we did a very simple study in order to isolate acanthamoeba from air conditioning outlets in wards and operating theatre in HCTM, and also to compare the isolation rates between two locations in order to identify the more prone infection settings in the hospital. So we identified and select 5 wards and 5 OT in HCTM as the sampling locations. And sampling in OTs, especially, it was done very early in the morning to avoid disrupting any surgical procedures. We were there actually around 6 in the morning to start the project. Okay, so dust from the air conditioning outlets or the vents was swabbed using sterile cotton swabs, moistened with page amoebic saline, and then immediately inoculated onto non-nutrient agar. And the red blocks arrows in the pictures shows where we swabbed the vents. Okay, all the plates were then sealed with parafilm to prevent contamination and brought back to the lab. And few drops of heat-killed E. coli was added to the plate. And actually the bacteria is used as the food source for acanthamoeba. And all these procedures were done aseptically. All the plates was then incubated at 30 degrees Celsius. That is the optimal temperature for acanthamoeba, and examined daily using inverted microscope up to 14 days for the presence of either the trophozoite or the cyst stage. And all the positive strains were classed to their groups according to the cyst morphology, and the findings were presented in the form of percentage and analyzed using chi-square statistical analysis. So let's have a look at the result. So I'm not sure whether this is good news or bad news, but all 5 wards and all 5 OTs were positive for acanthamoeba. And a total of 39 swabs with an isolation rate of 42.2% was actually the results of the findings in this study. And this is almost similar with the findings reported by Garcia Fonseca et al. In 2020, where around 35% of dust collected from air conditioning unit in the surgical center and ICU were positive for acanthamoeba. Now, if you look at the isolation rate, the ward has the highest rate of isolation at around 47% compared to OTs, but the difference was not significant. And this shows that the risk of exposure is almost similar in wards with heavy human traffics and in OTs where there is a controlled environment. And the isolation rate in OTs in HCTM is actually higher compared to a finding from another public hospital in Malaysia with only around 9.8% isolation rate. And we postulate that this may be due to the different practice in managing and maintaining both hygiene and sterile condition in OTs. For example, the use of different type and concentrations of disinfectants, which may have different effects. And as an added information, during sampling, we managed to collect a big cloud of dust particles from the air conditioning outlets in certain locations. And this proposed that poor maintenance and improper cleaning involving all parts of the outlets and grills may contribute to a higher isolation rate in HCTM. Now, the acanthamoeba isolated from all the samples were identified into group 2 polyphagites and group 3 calbutzonates. And this identification is based on the morphology and size of the cyst. And the thick double wall is clearly seen in this picture. The cyst has very thick double wall which protect them from harsh environment and desiccation, for example. So, the public health importance of acanthamoeba can be explained in two ways. First, the acanthamoeba is the genus most frequently found in nature, and some of the strains or genotype are able to infect human and animals. And most researchers reported group 2 and 3 as the most commonly isolated groups from both environment and clinical samples. And this research also identified the presence of this group as well. So the potential of this amoeba infecting individual, especially those who are at risk in a hospital setting, is possible. And the second one, acanthamoeba also serve as reservoirs for some pathogenic microorganisms. And few studies reported that these amoeba host at least one microorganism. And the most commonly identified pathogen is Mycobacterium species. And in a study done locally by Faiza et al. In 2017, she reported the presence of non-tuberculous Mycobacteria tuberculosis, Legionella species, and Pseudomonas species in acanthamoeba isolated from hospital environment. So these organisms were able to survive phagocytosis and multiply, making acanthamoeba their environmental reservoir and potential vectors for transmission to humans. So basically, based on the findings, we suggest that the air conditioner systems or the vents or even the hospital OTs and wards itself must be regularly cleaned, and the disinfectant used must be able to kill the C stage of acanthamoeba in order to prevent the possibility of transmissions. With that, I thank you.
Thank you, Dr. Anissa, for your presentation. Okay, our judges, please.
Yeah, okay, thank you, Dr. Anissa, for your presentations.
Yes, thank you.
Okay, from the isolated acanthamoeba, have you characterized it whether it's a pathogenic or non-pathogenic strain?
For the sake of this presentation, we only group them according to the taxonomical classification, which is group 2 and 3. But we have done some further investigation, and we do identify the genotypes of certain isolates from acanthamoeba that we isolated from the wards and OTs. And a few of them are of the pathogenic genotype, which is T4, T5, T11, and T15, if I'm not mistaken. So those genotype are actually the one that cause infection in human as well as in animals.
It is present in your samples?
Yes, it is present in the sample.
So with your results, show that our OT is contaminated with acanthamoeba is much more higher than the other local hospitals?
Yes.
Okay. Have you report this to the hospital management, your results?
Not yet, not actually yet, because we only started to look into the genotype of the isolates quite recently. So we are trying to gather as much information as we can and genotype all the isolates that we managed to get from the sample first.
Is there any cases of the acanthamoeba infections in our patients?
We do not have any reported case of CNS infection, but we do have cases of keratitis, but we are not sure whether it is from the hospital or from any other environment.
I think it's good future studies to see whether the acanthamoeba from the environment is the similar strains with the patients, and that gives some can help management to, let's say, reduce hospital infections.
Yes, of course.
Okay.
Quite comprehensive presentation. In your opinion, do you think there is a possibility that the source of contamination actually come from the same source? I mean, because the source because you're taking the sample from the aircon vent, right?
Yes, yes.
So, in your opinion, because the results comparing between wards and operation
OTs.
theatre, they're quite similar, right?
Yes.
So, do you think there will be? I mean, there is possibility that the contamination come from the same source or origin.
Yes, there is that possibility, because when you sample from air conditioning system, for example, they are using one system in the same building. So most probably it is from the same source. But we must again consider the outside source of the amoeba, because especially in wards, there are heavy traffic, human traffics, people coming in and going out, compared to OTs, which are strictly controlled. Only a few people can go in and out. So I would think that the ward has a higher isolation rate compared to OTs, but that is not the finding that we see. That is not the result that we see in this research. So I'm not sure about that. So the possibility is there.
Yeah, was there any trend that you see? Let's say, for example, those vents that got positive contamination, they are close to each other, or they are isolated from the others?
There is no such observation on that, actually, because what we are doing is, I would say, a conventional sampling. We just sample whatever vents that we manage to get ourselves to. So I'm not sure about that, but if you look at if you compare between our hospital and the one that we did the same study more or less, we can clearly see that the vent in that other hospital is, how should I put it, cleaner compared to ours, because we can barely get any dust from the grill of the vents compared to our HCDM.
Thank you, Dr. Nisa.
Yeah, welcome.
All right. So I think again, because we're running short on time, so we have to end this presentation. So thank you again, Dr. Anissa, for your wonderful talk. We just have to be more hygienic then in that sense. Okay, so moving on. Our next presenter would be from Afrina Africa from UMBI, and her presentation is on the prediction of terminal differentiation induced non-coding RNA, TINCR, driver regulator in triple negative breast cancer. So without further ado, please, the floor is yours. Hello, Afrina, are you in? Did you get disconnected? Okay, I think she got this. Oh, okay, there she is. Okay.
Please unmute mic.
Hello.
Hello.
Yes, boleh dengar. Loud and clear.
Okay, you're seeing my screen now, right?
Nampak. Clear, Doctor.
Okay, Assalamualaikum and a very good morning to panel of judges and fellow researchers. I am Afrina Afika Azman, a PhD student from UMBI under the supervision of Dr. Izani Azlina. So for the rapid fire session today, I'll be presenting my study entitled Prediction of Tinker Driver Regulator Terminal Differentiation Induced Non-Coding RNA in Triple Negative Breast Cancer. So to start off, a very brief introduction of my study. Breast cancer is the leading cause of death among women in Malaysia, and 1 in every 20 women are at risk of developing breast cancer in her lifetime. And that is 700,000 people, which is a substantial amount. So this makes it a very important field to explore in order to ensure a better understanding to help improve the statistics of breast cancer in Malaysia. So breast cancer heterogeneity can be found at different levels, but more recently, the further segmentation of breast cancer into intrinsic molecular subtypes based on different gene expression profiling have uncovered 5 intrinsic subtypes, such as luminal A and luminal B, normal-like, HER2-enriched, and basal-like, which is also known as triple-negative breast cancer. So there are distinctive survival prognosis across intrinsic subtypes, with luminal A being the most favorable and TNBC being the worst. And a baseline differential gene expression analysis from publicly available dataset GSC 58812 was conducted by my supervisor, Dr. Izani, in her previous work, with the aim to stratify signature markers in TNBC. And of 47 differential genes, Tinker was found to be among those upregulated in the metastatic and death patients with a fold change of more than 2.55 and a p-value of 0.0003. This data was then compared to the publicly available breast cancer database, the Kaplan-Meier-Potter, which prominently showed a statistically significant shorter DFS in triple-negative breast cancer patients with a hazard ratio of 2.69. So this high hazard ratio signifies that presence of Tinker in TNBC contributes to poor outcome. Tinker have been associated with the carcinogenesis of several cancers, whereby upregulation of aberrant Tinker expression often correlates with poor prognosis and survival. However, as of date, there are still no studies that links Tinker with TNBC, and therefore we are uncertain of the underlying mechanism of Tinker that drives the poor outcome in TNBC. So this then brings about the question of what are the regulatory factors of Tinker in TNBC? And to answer this question, we have established 2 objectives. One is to predict transcription factors of Tinker in the upstream of its promoter region, TSS. And 2 is to screen endogenous Tinker expression in a cell line panel to determine the right cell line model for the study. So methodology, data mining on Ensemble, Promoter 2.0, Prediction Server, Promo, and KM Plotter databases was carried out to predict Tinker promoter region and transcription binding sites upstream to Tinker TSS. The highest score of the predicted site was chosen for promo-putative transcription factors. Predicted transcription factors were analyzed further of their prognostic effects in TNBC on KM Plotter, followed by cross-validation of endogenous expression on Expression Atlas database. To answer the second objective, RT-PCR was carried out to determine Tinker endogenous expression in 6 breast cell lines and was cross-validated with Expression Atlas database. So, using the highest score of the predicted site for promo-putative transcription factors, there was a total of 84 transcription factors corresponding to Tinker promoter sites, results not shown here, and out of 84, 3 transcription factors such as the CEBPB, ELK1, which is also known as KCNH4, and NF1, located at these positions, were found to be prognostically relevant in TNBCs. From literature review, we found that they are somewhat important in tumorigenesis of breast cancer. And when cross-validated with public TNBC dataset, we found that ELK1, aka KCNH4, as well as CEBPB were statistically significant, but not for NF1. However, the reason why we included NF1 is because a few studies have reported its association in breast cancer with poor survival. And since it is predicted as one of the regulatory factors of thinker, we are interested to find out how it may drive poor outcome in TNBC. And here is the endogenous expression data of the transcription factors. And we can see that there is a high expression of CEBPB and ALK1 in our current in-house cell line panel. Higher endogenous thinker expression was observed in TNBC using RT-PCR, and TNBC cell lines are MDA MB468, MDA231, and HS578T, compared to luminal T47D and normalized breast 184A1 and MCF10A. Expression Atlas database also correlated with this observation. So this preliminary analysis narrowed down the potential driver mechanism of thinker in TNBC, and MDA468 and 231 will be chosen as our cell line model to elucidate the molecular mechanism of thinker driven by the putative TFs in TNBC. So with these findings, we are able to proceed to downstream studies following the establishment of stable cell lines of the ones mentioned earlier. And before I end my presentation, I would like to extend my acknowledgements to my supervisor, Dr. Izani, for being extremely supportive and helpful, my co-supervisors, Dr. Chin Seok Fong and Professor Dr. Noor Fadila Rajab, for always providing constructive outputs regarding this project. And finally, thank you to all for listening.
All right, thank you. Thank you, Afrina, for your presentation. Good. Judges, please.
Very nice project. It's just, I have some curiosity regarding the approach that you use. Why, when it comes to try to determine the possible transcription factor or regulator, why do you look at this expression level rather than looking at the, looking at the genome level, try to see what are the transcription factor site next to this, the genes that express the non-coding RNA?
We actually had a look at that as well. As you can see here, there is the locations predicted from Promo 2.0 that is near the promoter region of thinker. And these are the top 3, which is why we chose. And the reason why we do expression, to see the expression level, is just to sort of postulate what would happen if like certain expression levels were in the breast cancer cell lines. Perhaps higher would have more effect, lower, less effect or something.
May I know the reason why do you choose those 2 cell lines that you put at the end of your presentation for subsequent experiment?
Okay. So for my study, it is focused on TNBC. So these 2 are the most used triple negative breast cancer cell lines. And from our result, we can see that 468 have a higher thinker expression, endogenous expression levels. So perhaps with this, we can knock down and see the effect of what would happen then. And 231, even though it's not that high, we would still like to see how it would go about using this cell line, because a lot of previous studies actually use 231s mostly. And the reason why we might see a lower level here for our RT-PCR results is because it's a long non-coding RNA, so the structure has a lot of open binding sites, and we aim to improve the outcome of the RT-PCR results. We aim to run this again, perhaps with the addition of DNase treatment before doing cDNA, so to remove any like unnecessary bindings. Yeah.
Thank you.
So, Aprina, have you validated your expressions results?
We have validated here, RT-PCR, but only with 6 of these current cell lines, because the other 2 cell lines are quite slow growing. So after we have established the cell lines a little bit more, we would collect the RNA and then run for RT-PCR again with improvements this time, perhaps using the DNase treatment.
Okay, this is an expression that because usually expressions does not mean 100% translated, right?
Yes.
So from this are all but 6 types of expression gene, right?
6 types of breast.
Which one is the most the protein translated to the proteins?
I suppose the triple negatives, the 468 and the 231.
From the literature, there is.
From the literature, it's mostly 231s, but we just added 468 just to see if perhaps it could bring like a different view or something, because since a lot of people have already used 231, and I think another reason why we chose 468 is because from our qPCR result, it was higher. And so we were worried that if we used only 231, we wouldn't see the desired outcome.
You will proceed with the protein detections of all these expression gene?
Yes.
All right. So, with that,
we end our presentation for Afrina. Thank you very much for your work. All right. So for the next one, it's the final presenter for today is Ms. Vimala Valavan from the FSK, and her presentation is on the potential anti-MRSA activity of dimeric sesquiterpene compound isolated from Basidiomycete fungus. So without further ado, Ms. Vimala, the floor is yours.
Can you hear me? Good morning. Good morning. Can you see the slides that I shared?
Yes, yes, we can.
All right. All right. Hold on. Okay. I'm sorry for some slow things. Yeah, okay. Very good morning to everyone. I'm Vimala Valavan. Shall I start?
Yes, please. Go ahead.
Okay. Okay. Today I'm going to present on the research study entitled Potential Anti-MRSA Activity of a Dimeric Sesquiterpene Compound, DS, isolated from Basidiomycete fungus. So for the introduction, I'm going to go in an anti-clockwise rotation, so please do follow me. So first and foremost, without seeing the slides, I would like to generally ask, do you all aware what is antibiotic? If yes?
Yes,
okay,
yes.
Okay, let me, even though you all know, let me explain in a simple words. Antibiotics is a commercially available antimicrobial drugs that act against the infectious pathogen to treat the infectious disease, right? But the crisis that rise up nowadays is that infectious disease is much associated with the antibiotic resistance, which means the antibiotic is no longer effective. What we do is to treat the infectious disease, to running behind to treat the infectious disease, we tend to use the drugs in an indiscriminate manner so that it causes it's leading the rampant spreading of the multi-drug resistant bacteria or pathogens like human pathogens. For an example for the human pathogens that being experiencing the multi-drug resistant nowadays is Staphylococcus aureus. That is why there is an emergence of methicillin resistant, fusidic acid resistant, vancomycin resistant, vancomycin intermediate Staphylococcus aureus. This whole scenario contributes to higher rate of morbidity and mortality, possibly prolonged hospital stays, and also increasing the medical costs. All problems, these crises are involving the demands for the new solution, a new therapeutic new therapeutic alternatives as the antibiotics, the existing antibiotics is no longer effective against those evolved strains of Staphylococcus aureus. So the scientific community have been focused on the natural sources for the alternative, for new therapeutic alternatives, that is fungi or medicinal plants. For this study, we will be focusing an isolated compound from fungi, which is DS compound, which isolated from Basidiomyces fungus that has proven in vitro anti-MRSA activity. But we're going to test and evaluate whether it is best or better to be used as a single drug, single drug, or used in combination. All right. So for the whole study, we're going to evaluate whether the DS compound can be used as a new therapeutic alternative by testing the single effect of the compound, the efficacy of the compound when it combines with the existing antibiotics in clinical use, and also not to forget to test or evaluate the plasma protein binding, the protein binding affinities of the compound, because protein binding assay is to suggest the affinity capacities of the drug or novel compound to plasma protein in order to evaluate their bactericidal properties. So for the whole study, we're going to test the DS compound in MIC, the alone, when DS compound used in alone, how it works, and when it combined with the existing antibiotics, whether the MIC would be reduced compared when it used singly, and also the affinity of the compound when it used with the presence of plasma. So the most commonly used antibiotics in clinicals being used in this research, and some clinical strains, reference strains, and also the ATCC strains has been used, which are the multi-resistant strains of Staphylococcus aureus. So for the result has been simplified for the discussion. So MIC of DS from this research has found to be 3.91 to 7.81 microgram per mil for MSSA, FRSA, MRSA, and also BISA. So in short, we can say the DS compound is bactericidal against all MRSAs. For the results of combination tests, we can see the different combination gives a different outcome, which is very interesting. Let me see. The DS and oxacillin, which is oxacillin is a beta-lactam class of antibiotic. So when DS is combined with the beta-lactam, it shows all synergistic effect, which means it could reduce the MIC of individual antibiotics and or drugs, the compound, individual compound, and also the individual oxacillin MIC into 4 or 8-fold, except for Visa strain. And this is good that because the MRSA is a methicillin-resistant strain that is no longer having any results of antibiotics to be treated. So with this combination, we can see a future of a new therapeutic alternative where we're combining the DS as adjuvant to oxacillin, it works better. So for the next combination, DS and vancomycin, which is a glycopeptide. As we all know, if you're aware, the vancomycin is a last resort for the Staphylococcus infections. But as you know, when the exposure is increasing, when we are using it over the long period of time, we shall meet the resistance crisis again. So it's better to get a prevention better than cure. So we're trying to see the DS and vancomycin combination gives a synergistic effect against MSSA, which is a methicillin susceptible Staphylococcus aureus strain. And also it's partially synergistic against the one of MRSA and one of FRSA strain, which means the DS compound is able to act as adjuvant in order to enhance the efficacy of vancomycin by reducing the dose that we are using in clinical today. And next combination will be DS and fusidic acid. As in this research, we are using fusidic acid resistant Staphylococcus aureus. This outcome of synergistic and partial synergistic against the FRSA strain showed there is a light that DS compound can act as an adjuvant to fusaric acid, as well as to treat the difficult to treat pathogen, which is FRSA as well. Because if you can see, the reduction of the MIC is by 16-fold for MRSA, which is very, very high of reduction, and 2 to 8-fold for FRSA strains. And for the DS and gentamicin combination, it shows synergistic for FRSA and also partial synergistic for FRSA and MSSA. For the last combination, the DS and linezolid, even though linezolid is not a choice of antibiotic for the staphylococcus, but it still showed a synergistic effect for MRSA 43300, which is the ATCC strain. And the good thing about this compound is that no antagonism observed with any of the antibiotics. And the next phase, we're going to test for the plasma binding affinity of the compound, because it is a novel bioactive compound. Before we are able to test it as a new therapeutic alternative, we have to test whether it has a protein binding affinities, because the more it binds to protein when it enters to the system, it will limit the amount of free drug available that act against at the target sites. So it will reduce the metabolism and also elimination of the system. That is why we need to determine the protein binding affinities of any novel bioactive compounds. So from this study, we have an idea of the DS compound is bactericidal against all MRSA strains which were tested. And in ranking of order, we can have a best combination of a DS with existing antibiotics, which is for DS with oxacillin. It has to be investigated further so that we can get the oxacillin that is no longer effective against the Staphylococcus aureus strain, the multi-resistant Staphylococcus aureus strain, get into the clinical use, so that the oxacillin can be used back in the clinicals. And next is DS vancomycin strain, combination. And last combination that we can investigate further is DS fusaric acid. And I didn't mention here that VISA strain has to be specifically investigated, and more data has to be available and explored for the VISA strain, as it shows all the combinations showed indifference against the VISA strain. Okay, and last, I forgot to mention that DS is a moderate protein binding compared to vancomycin, which is a low protein binding drug, and also fusaric acid is a proven high protein binding drug. So with that, we can compare the DS. We can suggest and say that DS compound is a moderate protein binding. So with that, thank you.
Thank you very much, Primala.
All right.
So I invite Dr. Ekrab or Dr. Alfiza
to comment on the work.
Okay, I can hear it.
Primala, can you show me the table of results?
Okay, results.
Okay. Before that, what is the percentage of FRSA and VISA in Malaysia?
Sorry again?
The prevalence of FRSA and VISA in Malaysia?
FRSA is a clinical isolate. We're trying to, it's just that MRSA that we use is it's susceptible to fusaric acid. So we're trying to get the clinical isolate that could show multi-drug resistant environment.
No, I asked that there's the prevalence of FRSA and VISA in our country.
Oh, in country, FRSA, yes, it's quite prevalent, but VISA has not yet been documented. But yet it has been documented in Indonesia, the nearby country.
So we don't have any VISA right now?
No, but it's just we're trying to diverse the strain of Staphylococcus aureus to get the diverse results.
Okay, how many isolates that you use to test your DS and all these combinations?
Okay, for we use normal Staphylococcus aureus. We use 2 MRSA strains. we use true fusidic acid resistant strain, which is the clinical isolate. It can be the clinical isolate of MRSA, and also Visa strain, either vancomycin intermediate susceptibility. Sorry, vancomycin intermediate Staph aureus.
Okay, I just wonder, with your DS and Vanco combinations, why you get partial? It's only partial synergistic on MRSA. Because what is the treatment? What is the antibiotic used for MRSA infections?
For the Staphylococcus, generally vancomycin is being prescribed.
Not for Staphylococcus, generally for the MRSA, right? The MSSA we use.
Generally for the whole Staphylococcus infection.
And then when you combine the DS and Vanco, you got partial synergistic on MRSA?
Maybe because of the strain itself. The mutagenicity of the virulence factor of the different strains may be the cause of that. Maybe if we are using different strains of MRSA, maybe we could see a diverse result. But since I have just used two, I could not justify why is that. But it could be a good result, as it's still a partial synergistic, not an indifference outcome.
Yeah, because MRSA alone can be treated with vancomycin.
Yes. Yeah. For MRSA, because it's a methicillin resistant, but as the MRSA is a methicillin resistant, the octocillin is no longer effective towards the MRSA, right? But if you're seeing the result with the OXA, it has a very good outcome. It's all synergistic against MRSA, MRSA, and also FRSA, which that means we can focus on DS and oxacillin combination alone. It would be good enough, rather than we can focus on Vanco that being used currently in a clinicals. From this study, we can suggest that DS and beta-lactam combination would be better to be investigated further.
You need to test on more numbers of clinical isolates.
Yes, because as you asked, doctor, why the MRSA for the vancomycin and DS combination is not synergistic but partial synergistic. But when we are considering the DS and oxacillin combination, it is synergistic. Maybe we can investigate better on that combination rather than Vanco.
Yeah, it's good. It's good. Yes. It's good results because vancomycin is more toxic than the oxacillin.
Yes.
Okay. Thank you, Johanna.
Thank you too.
First of all, congratulations. I think a quite substantial amount of work you already have done for your research.
Thank you.
I'm just curious, out of many other compounds, why do you choose DS compound in the first place?
Okay, first and foremost, this is a project. We have an extension of project. It's a continuous project. At first, our focus was only on basidiomycin due to expertise. So basidiomycin was our focus. But when along the way, we have done a purification and isolation of compounds, and we have found the ceftriaxone compound. It's more studied for the antibacterial activities against gram-positive bacteria. So we have interested in those ceftriaxone compound, which is we've been purified out from the basidiomycin fungus.
Has there been any literature or any previous research doing on study on this compound?
Yes, there are many working on the species alone, which I can't reveal much on the species because it's a collaborative project under private PNC agreement. So I can't reveal much on the species, but yes, there is a literature review available on the species.
Okay. Looking at your slide here, can we know the dose of DS compound and also the corresponding dose for the antibiotics that you use for each test?
Oh, this is a result we obtained from minimum inhibitory concentration test, which is microbroad dilution. So we started off with 1 mg per ml, and we have diluted it, and we get this value of MIC. And for FIC, do you need the result? Okay, I will just focus on the oxacillin because from my study, I suggest that would be the best combination. So for the MRSA, the DS compound was from 7.81 microgram per ml dropped to 1.96. And for the oxacillin, it was 125 microgram per ml, which was dropped to 15.63. It reduced the MIC by 8-fold. And for the MRSA, another MRSA strain, it was reduced the oxacillin, the MIC of the oxacillin by 4-fold.
Because it's quite difficult for us to see the difference,
okay.
And also we're not so sure whether when you mention here synergistic, whether it's really summative or additive effect or is actually synergistic. Because synergistic should be more than the additive effect.
Synergistic, it's all was less than 0.50 of FICI, fractional inverted concentration index. That is all less than 0.5 is mentioned as synergistic.
Thank you.
Am I answered? Okay, right. Thank you.
All right. So are there any other questions for our last presenter? Yes? No? Okay. So thank you. Thank you, Vimala, for your presentation.
Thank
All
you
right.
so much.
So we are going to take a short break, 5 to 10 minutes. So I think we shall resume back at quarter to 12. The judges will convene and we will announce the winners for this afterwards. So take a break, chill, relax, grab coffee, tea, or whatever. We'll come back at quarter 2. All right. Thank you. Hi, hello, welcome back, welcome back. So I got here the results for today's competition. Is everyone here? Are all the presenters present today, right now? I think it, yes, I think we have most presenters. Okay. Yep, I take it that everyone is here. Okay, so without further ado, I will announce you the top 3 presenters based from what the judges have. Okay, look. What are you doing? Okay, scratch that, scratch that, scratch that after, be sorry. We're understaffed today. So we're managing as much as we can. So, okay, without further ado, 3rd place for this year's pertandingan poster preclinical category goes to Ms. Afrina Afika binti Azman from UMBI with her topic on prediction of terminal differentiation induced non-coding RNA tinker driver regulator in triple negative breast cancer. Okay, can we show her the poster? Ah, I see. Okay, all right. Okay, okay. So congratulations, Ms. Afrina. Okay, now 2nd place is Dr. Tan Jen Kit from the biochemistry department on his topic on comparing the metabolomic profiles of 3 different yeast crude extracts using LCMS. Okay, congratulations, Dr. Tan Jen Kit. And lastly, the 1st place for this year's preclinical poster presentation for the Minggu Penyelidikan, Medical and Health is none other than Ms. Lim Soo Min with her project of overexpression of LRG1 suppresses autophagy mechanism, possibly via TGF-beta superfamily in colorectal cancer from UMBI. So thank you and congratulations to all the winners and those who participated for this year's poster competition. Okay, so do we want are the judges wanted to comment anything? Okay, all right, okay, so they're bit occupied for now. So thank you again. So with that, I conclude our session for today. There are a few announcements. Hold on. There are a few announcements here that I would like you to take home. Number 1 would be the results will be this result, what that I have just presented will be on the website. You can browse all posters at our website. Everything, all work from those who are presented here and those that are that is selected, accepted, will be in our is already in our website. That's one thing. Okay, and then for those who are decided to submit their abstract as part of the publication in Medicine and Health, please make sure this is a note from Prof. Sijit is that please make sure that all the abstracts submitted are free from plagiarism and follow the format of Medicine and Health. And for those who wishes to not submit their work in Medicine and Health, please inform the respective committee member so that we take note on that. So congrats with that. I would say we end our session. Thank you very much for everyone who participated. Thank you very much for our 2 judges, Dr. Ikram and Dr. Alfiza. We on the behalf of the committee would like to apologize for all the technical mishaps that happened and okay, is happening right now. We hope to see you again next year. Hopefully you send more posters and it'll be more interesting talks further on. Thank you again for your time. And with that, my name is Dr. Muhammad Luqman. Goodbye.